morning, everyone. Today, we are discussing dilated cardiomyopathy. You might think that this is a very routine stuff. We know all about dilated cardiomyopathy or other cardiomyopathies for that matter. But the point is, in the last few years particularly, and even earlier than that, in the last few decades, a lot of information has accumulated on dilated cardiomyopathy and cardiomyopathies in general. That is why we are taking this discussion today. These are the things that we will be discussing today. As you know, dilated cardiomyopathy is a leading cause of heart failure in children. Where cardiac transplants are commonly done, this is the commonest indication for cardiac transplant in the older child. And you can consider dilated cardiomyopathy as the final common response of myocardium to various genetic and environmental insults. A little later, I'll elaborate on this particular theme. It can occur at any age. As far as children are concerned, if you take children up to the age of 18 years, it is in late teens that this is more likely to occur. It's more common in males. And remember, pediatric dilated cardiomyopathy runs a worse course compared to adult dilated cardiomyopathy. What is it that we today call dilated cardiomyopathy? It's a spectrum of heterogeneous myocardial disorders. It's not a homogeneous entity. These disorders are characterized by ventricular dilatation and depressed myocardial performance in the absence of hypertension, valvular heart disease, congenital heart disease, or ischemic heart disease. Remember, in this definition, you are not defining dilated cardiomyopathy as something of unknown etiology. You are excluding certain common causes of heart disease and saying that these should not be present. It suggests that other things could be present. Therefore, in children, the primary cause of dilated cardiomyopathy is unknown in 2/3. Put it the other way, in 1/3 of cases, we have some idea as to why this is occurring. And in adults, the number where the etiology is known is even higher. When the etiology is known, it tends to be known viral myocarditis in the past, a genetic disorder, or a systemic disorder with cardiac involvement. These are the common causes of dilated cardiomyopathy. Classification of cardiomyopathies and their history is an interesting saga in itself. We started in 1980 with dilated hypertrophic restrictive, non-classifiable, and arrhythmogenic right ventricular dysplasia made its entry. This continued so till 1996 when WHO added inflammatory and viral cardiomyopathy. Later, 10 years later, the American Heart Association wanted to classify it as primary and secondary, primary being classified as genetic, non-genetic, and acquired. Secondary as part of various systemic disorders. 2 years later, a similar classification was followed by the European Society of Cardiology, classifying each phenotype into familial and non-familial forms. A few years ago, the MOX classification came into vogue, where you would like to classify as the morphological phenotype, the organ involved, the genetic inheritance pattern, the etiologic annotation, and the functional status in terms of the ACC, AHA heart failure stages A to D, or the NYHA classification. So with all of that in the background, let's move to understanding this disease better. When you look at the epidemiology, it's hard to speak confidently about the epidemiology in a global way. You could say that the incidence is 36 per 100,000 in US, much lower in Japan. We do not know the actual prevalence in the underdeveloped countries. It may actually be higher. In the US statistics, elderly and blacks have a higher risk. How does gender influence survival? Note that it's more in males. There is conflicting data on this. And in the last 10 or 20 years, the common use of ACE inhibitors and beta blockers have improved survival in adults clearly. And remember, symptomatic children have a worse prognosis compared to adults. So when you look at causes of dilated cardiomyopathy, idiopathic, genetic, infectious, toxins, endocrine, inflammatory, infiltrative, autoimmune, neuromuscular, miscellaneous, different causes are coming in. Obviously, idiopathic is the leading cause, and in children, that is the cause in 2/3 of cases. So when you look at infectious cases, the commonest is viral, but it could be bacterial, fungal, parasitic. Among the parasitic, remember, especially in South America, Chagas disease, the trypanosomiasis is a cause. And the deposition diseases or storage or infiltrative diseases like hemochromatosis and amyloidosis are important causes. You know that anti-malignant chemotherapy is an important cause. Toxins like alcohol, cobalt, nutritional deficiencies, inflammatory and autoimmune diseases, all these could be causes underlying dilated cardiomyopathy. When you look at genetic causes, you can classify them as with and without neuromuscular disease, because in children, neuromuscular disease is commonly associated with cardiomyopathy. Duchenne's muscular dystrophy and myotonic dystrophy and Friedreich's ataxia being common examples of this. There are those without neuromuscular disease like arrhythmogenic right ventricular cardiomyopathy. You can have endocrine disorders. You have miscellaneous. I've included some of the adult causes also here like peripartum cardiomyopathy and some specific entities like stress-induced like Takotsubo cardiomyopathy, which are adult issues. We will not be discussing that. The genetics of dilated cardiomyopathy can unravel now. As of today, more than 50 genes have been identified that harbor mutations for dilated cardiomyopathy. Every day, this number will keep increasing. So we would say that there may be an underlying genetic cause in 30 to 50% of patients with dilated cardiomyopathy. And when there is a familial pattern, it could be autosomal dominant, it could be X-linked, autosomal recessive, or mitochondrial. Autosomal dominant inheritance itself has 3 types, and X-linked cardiomyopathy is a dilated cardiomyopathy in adolescents and young adults. You might have heard of the Barth syndrome, where dilated cardiomyopathy is associated with skeletal myopathy and neutropenia in infants. The Danon disease, where cardiomyopathy is associated with skeletal myopathy and intellectual disability. Here, the initial presentation may be as hypertrophic cardiomyopathy that merges into dilated cardiomyopathy later, and there may be female carriers who tend to develop late onset dilated cardiomyopathy. The genetics, as you know today, is becoming more and more molecular. So when you look at the molecular genetics of dilated cardiomyopathy, the genes encoding dilated cardiomyopathy could be found at all levels of myocardial structure. It could be in the nuclear envelope, it could be in the sarcomere, it could be structural proteins, it could be ion channel proteins, and they may be unclassified proteins. And this diagram of the myofiber with the sarcolemma here, cytoplasm here, and here, this gives you a class of different genes, and how these and long left and I should make a special mention in particular chronic alanine of the alanine which is associated with high rate conduction and marriage and seven. So this is reminds us between myocardial dysfunction. They may be causing disruption of the cytoskeletal integrity. They may be impairing force transmission. generation of force may be poor, the nuclear function could be defective, the iron flux may not be properly regulated, the stress adaptation could be imperfect, or you do not know. But the point is, these are different mechanisms by which a wide variety of insults can lead the heart down a common pathway of destruction, produce ventricular dilatation, ventricular dysfunction, and heart failure. Now, from the esoteric aspects of dilated cardiomyopathy to the bedside, what is the sort of history that you would be getting? The symptoms would correlate with the degree of myocardial dysfunction. You may get a very acute onset in viral myocarditis. In the older child with established cardiomyopathy, it's exertional dyspnea and fatigue that would dominate the presentation. In infants, tachypnea, dyspnea, irritability, and poor feeding, symptoms of heart failure. These are the things that would be there. And when you're eliciting history in a patient with suspected cardiomyopathy, you should be asking for a history suggestive of recent viral infection, either respiratory or gastrointestinal, a family history in the last 3 generations, exposure to cardiac toxins, and rare diseases, if you're practicing in South America or in certain parts of the United States, travel to endemic areas like Lyme and Chagas disease. Remember, there's a lot of mobility in the world today, so you could get these diseases in your practice. Or a tachyarrhythmia could be the reason for the cardiomyopathy. When you examine the child, see whether the child is comfortable. The child in acute cardiac failure has anxiety, tachypnea, fast heart rate, he's sweating, grunting may be there, maybe obviously orthopnea. The child may be wheezing, especially if this is unresponsive to conventional sympathomimetic agents. You should suspect that cardiac failure is the underlying reason. The blood pressure could be low. The heart rate is almost invariably high. I would say almost, because occasionally the myocarditis can result in heart block. The saturations are normal unless there is pulmonary edema. JVP is raised. There is cardiomegaly. There may be left parasternal heave in long-standing cardiomyopathies. When you listen to the heart sounds, the first sound is muffled. The second sound is normally split, but the P2 may be loud. You could hear a gallop of S3 and S4. You may hear a mitral regurgitation murmur, but quite often, even when significant MR is picked up on echo, you may not hear it, and the intensity might improve as the cardiac function is improving. There could be a pericardial effusion. There's a hepatomegaly, ascites, pretibial edema, all if the child is in gross heart failure. And evidence of low cardiac output like cool extremities and prolonged capillary filling time could also be there. ECG, nothing specific. Sinus tachycardia, there could be an arrhythmia. You could have a CT or VT, or you could have a heart block. You may find some LVH because the dilated LV may be manifested as an LVH. Non-specific ST changes may be there. It's very important to look at the ECG carefully to exclude Al-Kappa and PJRT. Look at this. This ECG shows Q in lead 1, AVL, V4 to V6. In fact, some ST elevation also in this lead. Take a good look at this ECG. This ECG you should never miss. This is Al-Kappa. Remember, most infants, when they present with dilated cardiomyopathy, Al-Kappa is in the differential diagnosis. In fact, I always exhort my students to think that any dilated cardiomyopathy that you see in an young infant is Al-Kappa unless you prove it otherwise. So with that concept, go aggressively look for the coronary artery origin. Proactively look at the ECG for the Q waves in lead 1 and AVL. It will pay dividends. Also, this ECG. This is, if you can see, you have an inverted P in 2, 3, and AVF. The rate is only around 150, 160. You don't have a grid to actually calculate the rate in this. So when you find a narrow QRS, a long RP tachycardia with a rate that is less than 200 per minute and a negative P in inferior leads, it is PJRT. Why is it important? The child will present with dilated cardiomyopathy-like presentation, and unless you're carefully looking at the ECG, there's nothing else that is going to tell you that this is PJRT. And here the treatment is antiarrhythmic and at some point RF ablation. Chest X-ray is cardiomegaly. The cardiomegaly is contributed by LA and LV. Left main bronchus may be elevated, as if you can make it out here. Pulmonary venous congestion is obvious. There could be pleural effusion or thickening of the interlobar septum. Obviously, echo, is the most utilized non-invasive method for diagnosis and also for monitoring progression of the disease. The sine qua non is dilated, poorly contracting left ventricle. Cardiac chambers are enlarged. LA and LV are always enlarged. RA and RV may be enlarged. And when you look at the LV, the end diastolic volume, end systolic volume, both are increased and the ejection fraction is low. Look for coronaries to exclude alpha. Be sure that you're not missing any correctable cause like a coarctation or aortic stenosis. You may find endocardial fibroelastosis in young infants. Vena cava and hepatic veins are dilated, reflecting the right-sided venous pressures. Pericardial and pleural effusions may be present. Mitral regurgitation is common. It is due to annular dilatation and it is a prognostic implication for the child. Tricuspid regurgitation may be present due to pulmonary hypertension. RV dilatation and tricuspid regurgitation are bad prognostic markers. In fact, additional RV involvement in a dilated cardiomyopathy is a marker of poor prognosis. This is the classical echo where you find the dilated left ventricle. It's poorly contracting, it's thinned out, and the LA is enlarged. The degree of dilatation and the appearance of sphericity for the LV is a bad prognostic sign. This is to show the mitral regurgitation, some endocardial thickening. Do you catheterize your dilated cardiomyopathies? Ordinarily not. But if you're dealing with an adult, generally adult cardiomyopathies tend to get classified as ischemic and known as ischemic. So to document coronary artery anatomy, it may be done. If you are in an academic environment and endomyocardial biopsy is commonly done, endomyocardial biopsy could be a reason to do catheterization. And also in academic setups, evaluation of therapy after you have instituted your diuretics, vasodilators, ACE inhibitors, you want to know what is the cardiac output, what is the pulmonary capillary bed pressure. For these purposes, you may catheterize. But in conventional practice, dilated cardiomyopathy does not require catheterization. So what do you do to diagnose and evaluate a dilated cardiomyopathy? Of course, you have done an echo and you have seen that there is a dilated ventricle which is poorly contracted. Today, these 4 steps are important when you look at a child with dilated cardiomyopathy. You must try to find an etiology. You must assess what is the degree of remodeling, thereby trying to predict what is the chance for reverse remodeling and acquiring normal shape. Does this child require an ICD, implantable cardioverter defibrillator, or other form of device therapy? Can you detect a pre-DCM phenotype in a family where there is an index case with dilated cardiomyopathy? These are the considerations that would be in your mind when you are approaching a child with dilated cardiomyopathy. So evaluation of etiology. Remember, in children, you should always presume that cardiac failure is due to a correctable cause. So it is up to us to be certain that there is no correctable cause before we affix the label dilated cardiomyopathy to a kid. Obvious causes are alpha, coarctation, tachycardiomyopathy. We just shouldn't miss these. And routine etiological workup, you would do the blood counts, liver function, all those things. And By history, you would like to exclude genetic causes because looking for genetic mutations is not cost effective as of today unless there is a specific reason. So how do you assess remodeling? Look at the extent of LV dilatation and contractile impairment. This is the major determinant of adverse cardiac outcomes. And the goal of therapy is reverse remodeling of left ventricle. So how much remodeling is there to begin with is what you want to know. And what are the adverse predictors for reverse remodeling? In other words, where your treatment is less likely to be successful, the extent of left ventricular wall thinning and dilatation. If the myocardium has been extensively replaced with fibrous tissue, that is an adverse predictor. Myocardial fibrosis detectable on techniques like cardiac MRI is an important marker of poor prognosis. The degree and the presence and degree of functional mitral regurgitation, dysynchronous ventricular contraction, areas of ventricular contracting dyskinetically. If the other chambers are involved, that is, if the right ventricle and right atrium are also enlarged in a dilated cardiomyopathy, these are some of the predictors that our treatment may not succeed in restoring this left ventricle to its normal shape. You know that 3D echo and cardiac MRI are extensively used today. This is to show the ventricle in systole and diastole in MRI. And the LA dilatation, the LA volume has been related to the adverse outcomes in adults. RV volume and function, which is best assessed by cardiac MR, is also a predictor of poor outcome. We mentioned functional mitral regurgitation. The more the LV size and the more spherical the LV is, mitral leaflets tend to get tethered and annulus will dilate, so the mitral leaflets do not coapt, resulting in functional mitral regurgitation. As functional mitral regurgitation sets in, this would perpetuate LV remodeling. The LV tends to become more and more spherical. This would increase morbidity and mortality. Even when or rather, independent of the LV ejection fraction, the functional mitral regurgitation worsens mortality. And therefore, in adults, it has been shown that if you reduce functional mitral regurgitation with optimal medical therapy, cardiac resynchronization, or surgery, you have an improvement in transplant-free survival. Myocardial fibrosis, we made a reference earlier to. We are speaking to replacement fibrosis. Replacement fibrosis means the myocardium has been scarred. This may be the result of inflammation, injury, or necrosis. So, in all advanced dilated cardiomyopathy patients, you can expect it. In this pathology specimen, this is the fibrous tissue which is being pointed out. And in the MRI, you can identify the fibrous tissue in the mid-wall. Some epicardial fibrous tissue is common, subepicardial fibrous tissue is common, but mid-wall fibrosis, which is recognized by in gadolinium scan with a late gadolinium enhancement, which becomes brighter later during the course of acquiring the images. That is very specific for myocardial fibrosis, and that's a very negative prognostic marker. So if you look at this very busy slide, you don't need to look at it in great detail. This is only to tell you that when you assess a dilated cardiomyopathy, you are assessing the patient to guide your therapy and to predict prognosis. So what you are trying to see is what is the stage of left ventricular remodeling. It could be latent, it could be established, or it could be advanced. In a latent remodeling, you could possibly be looking for an abnormal gene mutation, an altered biomarker like an elevated BNP, and our treatment could try to retard remodeling, which could be achieved by neurohormonal blockade, perhaps molecular and genetic therapy in the years to come. Remember, particularly for skeletal myopathies, gene therapy is emerging. And these patients need to have surveillance with imaging and biomarkers like BNP. So this is the latent one. How do you see that? You're evaluating the members of a family where an index patient has already been affected. In established dilated cardiomyopathy, there is no doubt about the diagnosis. But here again, be sure that you know about the extent of replacement fibrosis. If it is less, it is better for the patient. Look for functional MR, LV dysynchrony, evidence of active myocarditis. And it's not retarding remodeling, it is reversing remodeling that you try here, for which there are various techniques, which include not only neurohormonal blocker, CRT, mitral valve interventions, molecular and gene therapy, immunosuppressive and antiviral treatment if there is an acute active inflammation shown on the biopsy. If it is advanced, obviously there is extensive replacement fibrosis. There's probably right ventricular dilatation as well. People have tried things like stem cell therapy here, and this is the sort of patient who is likely to end up in a transplant or die sooner. And patient may go on an LV assist device. So transplant and destination therapy LV assist device could be used in these cases. So the status of dilated cardiomyopathy at presentation as evaluated by you is a guide to therapy. So you are looking for indication for an ICD. In selected patients, ICD reduces the risk of sudden cardiac death. Today, we would recommend it for those with reasonable life expectancy and quality of life. Why do we say that? Now, supposing the patient is moribund with a extensive muscular dystrophy, giving him an ICD may not carry much sense. But on the other hand, the normal patient where the problem is purely cardiac, with a history of ventricular arrhythmia and hemodynamic compromise, it is a secondary prevention of sudden death, it could be used. Or even in the absence of this, the NYHA class 3 or class 4 patient with an ejection fraction less than 35%, despite optimal medical therapy, there's an indication for ICD. Remember, even with an EF higher than 35%, and even without such gross advance in the functional class, indication for ICD exists if you know that it's a lethal mutation, like the LMNA mutation. How do you identify a pre-DCM phenotype? It's very nice if you can. The rationale being to institute early treatment to prevent adverse remodeling, heart failure, and thereby to increase life expectancy. And the principle is that the established DCM phenotype should be preceded by subtle signs of myocardial injury, dysfunction, or remodeling. So if we can detect this state, we can intervene more effectively. Unfortunately, we will be detecting this if only you have a random chance of doing an echo in a patient, or if you're screening the family of a patient the index patient affected with disease. And when LV is dilated without systolic dysfunction, this is a well-defined precursor of inherited dilated cardiomyopathy. I'll refer to this in little detail later. So this disease slide again tells you about the various diagnostic strategies. You would look at the detailed history, initial diagnostic workup. You are in an adult, you are classifying as ischemic versus non-ischemic. Accordingly, you are taking your test. I will not spend more time on the disease slide. Let's come to treatment of dilated cardiomyopathy. In treating dilated cardiomyopathy, let's identify the clinical situation that we are dealing with. It could be asymptomatic left ventricular systolic dysfunction. It could be an acute decompensated heart failure, or it could be chronic congestive heart failure. Asymptomatic LV systolic dysfunction is a depressed LV systolic function with a subnormal LV ejection fraction, regional wall motion abnormality, or both. You recognize it by randomly getting a chance to do an echo in a normal patient as part of some evaluation, or by focused investigation of a family of an affected patient. And once you have recognized this, let's first manage contributing conditions. You know that hypertension, diabetes, dyslipidemia, obesity, these can have an adverse effect on the LV function. So let's control these. and then look at neurohormonal blockade like ACE inhibitors, ARBs, beta blockers. Arrhythmias should be managed, and if necessary, you should use an ICD. And you should avoid drugs that could potentially precipitate heart failure. For instance, calcium channel blockers and antiarrhythmic agents with negative inotropic action. And these children would require a close monitoring of their progression. If they are asymptomatic, you may see them yearly. By definition, you have taken this as an asymptomatic group, so they should be seen yearly. Management of congestive heart failure is the second common presentation, that is established cardiac failure. Please note that in this class, I would not be having the time to discuss drug therapy of congestive heart failure in great detail. I'll make references to principles and groups. So clinical congestive heart failure will get manifested with low cardiac output, fluid retention, increased peripheral vasoconstriction, and with metabolic problems. Each issue would need to be addressed. So our aim is to increase cardiac output by one, increasing the cardiac contractility, then reducing the preload and reducing the afterload, optimizing the preload, I should say, not simply reducing, and reducing the afterload. That should improve cardiac contractility. And you can enhance tissue oxygen delivery by correcting anemia. You need to sustain vital organ function. You need to improve nutrition. These are the general principles of treating heart failure. And if the child is in acute decompensated heart failure, you are likely to use inotropes. You have dopamine, dobutamine, milrinone, all your list. And you could use vasodilators like nitroprusside, nitric oxide sometimes in the acutely sick child. And you must know about two new drugs which have come, levosimendan and nesiritide. They are no longer very new, but relatively less commonly utilized. Diuretics, of course, is the mainstay of giving relief to the patient. A continuous infusion is better tolerated than a bolus dose. And when you are starting ACE inhibitors or beta blockers, remember the acutely decompensated patient is unlikely to tolerate this. Whenever you are starting it, start in a low dose and increase as tolerated. It may require intubation and ventilation. You may need to look at the fluid and the electrolyte balance carefully and the nutrition carefully. Levosimendan is a positive inotrope with vasodilator effect. It is a dose-dependent reduction in the cardiac filling pressures. It increases the cardiac output when it is given an IV to the acutely decompensated patient. There are several trials which have evaluated the benefit of levosimendan over other conventional drugs, and in general, they have not shown any clear benefit over conventional treatment in the long run. But definitely, it is an additional choice in the pediatric intensive care unit for a critically ill child who is not doing well with conventional therapy. Similar would be our statement on nesiritide. Nesiritide is a recombinant BNP that reduces preload and afterload by promoting diuresis, natriuresis, and arterial and venous dilatation. So if a drug can eliminate the extra fluid, if it can cause arterial dilatation, and if it can cause venodilatation, it would improve cardiac output because the loading conditions are improved, even though it is not an inotropic agent. There are small studies on the use of nesiritide in acutely sick children. The data shows that use of nesiritide as an addition to conventional therapy improves the urine output, the renal parameters, and the cardiac function. Remember, it's not recommended for routine use in acute decompensated heart failure. In chronic congestive heart failure, you have all the drugs to use. You have your various diuretics. You have digoxin. Still, a maintenance dose of digoxin could be beneficial. You have vasodilators like captopril, enalapril, lisinopril, and they are not tolerated. You could use ARBs like losartan, candesartan, valsartan. Beta blockers, carvedilol and metoprolol have best data in support. Carvedilol also in randomized controlled trials have not shown with a great effect, but there is very substantial benefit for carvedilol in adults, and in small studies in children it has been found to be beneficial. So we would definitely recommend carvedilol to the child with chronic congestive heart failure. Other measures, the child may require antiplatelet and antithrombotic agents. Specific causes could be treated like carnitine deficiency or vitamin D deficiency, RF ablation, antiarrhythmics if it's a tachycardiomyopathy, and CRT, which is a very distinct role in the management in adults, has a smaller role in children. What is CRT? You are using biventricular pacing, a right ventricular pacing along with a pacing lead deep into coronary sinus to pace the left ventricle. When there is a dyssynchrony between the ventricles, biventricular pacing reduces the dyssynchrony, electrically adjusting the timing of RV and LV contraction. This optimizes ball motion, increases filling time. In the best response cases, there is an instant increase in cardiac output. And this may allow for reverse remodeling and delaying disease progression. As I said, most of the data is in adults, where trials have shown in specific groups that there is reduction of symptoms, increased exercise capacity, decreased mobility, and some reduction in mortality. In small subgroups in children with dilated cardiomyopathy, especially if there is a left bundle branch block, it could be beneficial. So CRT in children is indicated if there is advanced heart failure not responding to optimal medical therapy, those with a poor ejection fraction and left bundle branch block. The effectiveness of CRT in children is more difficult to evaluate compared to adults because the anatomic substrates, if there is congenital heart disease, is complex. And again, in post-hoc congenital heart disease, the scar formation from multiple cardiac surgeries could be a problem. And children tend to have more right bundle branch block and right ventricular failure rather than left ventricular failure, unlike adults. And in this, the benefit of CRT is less compared to left bundle branch block. And we don't have any randomized controlled trial data. And in one particular multi-center retrospective analysis of a few children, the young adults, CRT was associated with an improvement in ventricular ejection fraction. And these were all children and young adults with a prolonged QRS duration. So CRT has a very limited role in a small subgroup. When it works, it gives good results. Cardiac transplantation is recommended for end-stage heart failure refractory to medical therapy, what would be called stage D in the Heart Failure Association classification. And it's considered for less severe heart failure, which is associated with severe limitation of activity, significant growth failure, intractable arrhythmias, or restrictive cardiomyopathy where your treatment doesn't work. And the decision should be based on the expected survival with medical therapy, quality of life, alternative options for treatment, and estimation of survival post-transplant. And if you look at the outcome of cardiac transplantation in children, some international data with more than 12,000 pediatric heart transplants done from 1982 to 2014 has shown that there's a median survival like 13 years in adolescents and 21 years in infants. So that's a very impressive benefit. And the mortality related to transplant is highest in the first year. And survival has improved over time. With the 5-year post-transplant survival, you would expect today to be 82% in the current era. Now, against this background, let's see what is the natural history of dilated cardiomyopathy. To begin with, we should say that this is difficult to establish because we are dealing with a heterogeneous spectrum. A familial cardiomyopathy with a specific genetic mutation would run a different course from a viral myocarditis presenting with extensive myocardial scarring. Also, the disease tends to have an insidious onset. It can be missed for prolonged periods. We already referred to the asymptomatic LV systolic dysfunction. A recent onset is a more favorable outcome because you can intervene before the LV has been irreversibly damaged. And if the baby or the child is presenting with 3 months or more of severe clinical decompensation, it is worse. And if you take idiopathic dilated cardiomyopathy versus severe viral myocarditis or a bad genetic mutation, the idiopathic DCM has a better prognosis. And if you have only mild LV dilatation and no other chambers are enlarged, that is a good prognosis. But as a general statement, pediatric dilated cardiomyopathy has a worse prognosis compared to adults. Can we predict what are the indicators of poor prognosis? There are a number of them. LV and RV enlargement. LV is anyway there, the additional RV enlargement. And reduced ejection fraction of both LV and RV. The lower the ejection fraction, the worse the prognosis. Clinically, finding is an S3 gallop, right-sided heart failure, like elevated JVP hepatomegaly, elevated LV filling pressure, microregurgitation which is significant, pulmonary hypertension. If there is left bundle branch block, recurrent arrhythmias like ventricular tachycardia, other organ dysfunction, kidney and liver in particular, grossly elevated BNP, a persistently elevated troponin, in the exercise evaluation, in physiologic exercise assessment, a VO2 max which is less than 10 to 12 ml per kg per minute, an advanced NYHA functional class, the elderly, and in endomyocardial biopsy, you find myocytolysis. If the cardiac MRI shows late gadolinium enhancement in mid-wall, that is the evidence of fibrosis, and this is unlikely to reverse, and therefore this is associated with higher mortality and major cardiac events. So among the investigational parameters, this is a very, very important predictor of adverse prognosis. Then, if they tolerate beta blocker, it is better. Their inability to tolerate beta blocker would predict poorer survival. And when they die, 2/3 of children would die from chest pump failure, and 1/3 would have sudden cardiac death. So the take-home message is, there are tremendous advances in the understanding of dilated cardiomyopathy in children in the recent years. Etiology is clearly understood in at least 1/3. This number is going to increase in the years to come. And today, when you assess a dilated cardiomyopathy, you should be evaluating for etiology, assessing remodeling, and customizing therapy to the stage of treatment. High-risk children need consideration for ICD, and newer treatment modalities like CRT may play a role in a small subset of children with dilated cardiomyopathy. I shall acknowledge the help given to me by Dr. Minu Thomas, my colleague in this presentation, and thank you. I would be happy to answer any questions. You can ask your question